Hello everybody, welcome. Today I'm going to share with you the features of congestive cardiac failure on a chest x-ray. Now we're going to start by having a look at this normal chest x-ray, and I want you to imprint this image on your mind. Have a look at the costophrenic angles, look at the lung fields, the pulmonary vasculature, the heart size, and then we look at images later on in this talk. You can think back to this image and notice the differences for yourself. Now I want to stress before we get started that congestive cardiac failure is a clinical syndrome. It's something that we diagnose clinically, and we can use radiographic features to supplement that clinical information, but we're not going to make the diagnosis on chest x-ray or on CT scan. We're going to use these features to help us supplement the clinical picture. So congestive cardiac failure is when someone's heart has either a structural or functional anomaly that renders it unable to pump blood out effectively and perfuse end organs, and because it's a closed system, it's then also unable to accommodate incoming pulmonary blood, and leads to increased pulmonary pressures and actually increased pulmonary blood volume. Now on a chest x-ray, it's very difficult to see that decreased capacity to expel blood from the heart, but what we can see very clearly on a chest x-ray is features of pulmonary congestion and ultimately pulmonary edema. So that's what we're going to be doing in this talk, is looking at the features of pulmonary edema, and it actually happens in a very logical and stepwise fashion, and it goes through these three well-identified phases. Now these happen in this order, and it happens as the pulmonary capillary wedge pressure increases to certain levels. So first we'll get redistribution of blood around the lungs, then we'll get seeping of fluid into the interstitium out of the extravascular space, and eventually fluid filling the alveolar spaces, filling the airways, as well as fluid going out into the pleural space and giving us pleural effusions. So let's have a look at redistribution. Cast your eyes to this image, and the more images you look at, the more you'll realize that these vessels here in the superior portions of the lungs are grossly dilated, and these are not normal. So if we look here, you can clearly see these vessels in the upper portions of the lungs. Now, normally these vessels are kind of collapsed on themselves. Gravity will mean that the lung vasculature at the lower zones will be filled, and it doesn't really need to fill up the vasculature here in the upper portions of the lungs. Now, as the pressures and the volumes increase from that inability of the heart to take up that blood coming from the pulmonary circulation, we get increased pressures opening up those pulmonary vessels, and this is an accommodation mechanism for the lungs, and this is the first thing to happen as our pulmonary capillary wedge pressures increase. So whenever you're looking at an x-ray, that's the first space to look at if you're suspecting congestive cardiac failure, is look at those vessels. Can you see them clearly? Are they dilated? Now we're going to look at the same image. As those pressures now increase further, we can have fluid seeping out into the interlobular septa and actually cause interlobular septal thickening with that fluid. Now it's often quite difficult to see, and you need to look quite carefully on the image, but if you look at the periphery of the lungs here, we can see these thin septal lines about 2 to 3 centimeters long, and they are abutting the pleura at a perpendicular angle. And this is what's known as curly B lines. So that's just an indication that fluid has now seeped out from our vessels into the interstitial space, causing interlobular septal thickening, and these are called curly B lines. Lines seen closer to the center of the image or by the aorta, those are known as curly A lines, and people will often name these lines seen here as curly C lines. The way I remember this is that B lines are by the border of the image, A lines are by the aorta or the center of the image, and then in between those, the central portion is the curly C lines. Now we can see this person has a pacemaker and a large heart, so this is showing us that this pulmonary edema is probably cardiogenic in cause, and we can infer that maybe this is congestive cardiac failure that's causing this pulmonary edema. Now, as these pressures now increase further, we get fluid seeping out into the alveolar spaces, spreading between the pores of Kohn, causing fluid to fill these spaces. And we can see here that there's our bronchi here are patent. These are giving us air bronchograms here, but the alveolar spaces next to it are completely filled with fluid. They're completely opacified. They're not the normal lucent lung that we see. And so this can often look like consolidation, but generally we will see fluid densely filling these alveolar spaces, causing dense opacification of the lung fields here. And what we've got here is we're losing our costophrenic angles. Here we've lost it completely, and we've lost our left diaphragm. We've probably got a large pleural effusion on that side, which is a very common occurrence in congestive cardiac failure. Again, this heart is large. we can infer that maybe this is cardiogenic in cause of this pulmonary edema. And when you see an image like this, you know that the severity or the grade of pulmonary edema is very high, because we've got all the features of congestive cardiac failure on this image. So let's have a look at an example case. Again, we've got all our features. So if we look here, we've got dilated pulmonary vasculature at the top here, accommodating that redistribution of blood. We've got fluid in our horizontal fissure here. We've got curly B lines there, interlobular septal thickening. We've got fluid within the alveolar spaces here. We've got a large right-sided pleural effusion, and we've also lost our left costophrenic angle and left diaphragm. So we've got bilateral pleural effusions here. And as I say, congestive cardiac failure is a clinical diagnosis. We can't always tell from an X-ray what the underlying etiology is, and we can't tell what the precipitating factor that's caused this person to now go into congestive cardiac failure. But when you see an image like this, you can see stenotomy wires that have closed the previous stenotomy. We can see surgical clips here, and if you look closely, we can see evidence. It might be difficult to see here of previous stenting in this heart, so most likely this is cardiogenic in cause, and it's probably ischemic in cause. Those are the radiographic features on a chest x-ray. I just want to show you a CT scan quickly before finishing off, because for me it just solidifies the concepts a little bit clearer, and it's a bit easier to see on this axial CT. So here we've got a large heart, and this is someone who has congestive cardiac failure. We've got a vessel that is larger than its accompanying bronchi, which it shouldn't be. The vessel should normally be the same size or smaller, and this is showing us that that vessel has had to accommodate some extra pressure, some extra volume. We've got fluid within our interlobular septa here. We've got fluid in our fissures. We've got large bilateral pleural effusions here. This is the fluid that's seeped to the back of the patient. As well as, if you look closely, this is a subtle sign, but something that's quite good to recognize on a CT, is that our lung is far more loosened here at the anterior portion of the patient compared to posterior. It kind of gets more pacified as we go posteriorly, and that's indicating that this is fluid that by gravity is seeping towards the posterior side of the patient who's actually lying on their back here. And that's another way to differentiate. Is this like a dense infective consolidation, or is this fluid that can kind of flow freely within the lungs? So that's all for pulmonary edema. Again, if you're the clinician who is looking at these images and needs to now act with this patient, it's very important to go and find the underlying etiology. Is there a valvular problem? Is there a hypertensive heart disease or a cardiomyopathy? And then you need to find out why this patient has now exacerbated that cardiac failure. Are they anemic, or is there sepsis on board, or are they thyrotoxic? And you need to address those issues. Congestive cardiac failure has a very poor prognosis, and it's often got worse mortality or 5-year mortality than various cancers. So this is something that's serious and needs to be dealt with and needs to be spoken about with your patients, who will then need to make either drastic lifestyle changes or really get on top of the medical management. And then you can use serial imaging to see how you're managing the pulmonary edema. Are you on a winning footing, or do you need to step up your management? So I hope that helped. If it did, please hit the like button and subscribe to the channel, and I'll see you all in the next video. Goodbye, everybody.